Shall I start, Dr. Sandeep?
Just a minute. Yeah, please start.
Okay. A very warm welcome to all of you who have joined us today for the third talk in the Jewel 50 series of the Indian Academy of Cytologists. I, Dr. Radhika Srinivasan, the Secretary of IAC, extend to you a very warm welcome. Today, we are having Dr. Andrew Field as our speaker. And Dr. Andrew Field is a jewel from the shores of Australia, Sydney to be precise. And when I say Sydney, it's going to trigger in all of us who are cricket buffs memories of the recent cricket series in Australia. But Dr. Andrew is more of a football buff, I understand, than cricket. So welcome, very warm welcome to you, Dr. Andrew, on behalf of the Indian Academy of Cytologists and from all of us here in India. Thank you for accepting our invite, and again, a very warm welcome to you. Dr. Andrew is the president of the International Academy of Cytology, and the topic he has chosen is breast FNAC. And we all know that recently India has seen a sort of a decline in the metros, especially of the practice of breast FNAC, which is getting slowly replaced by core needle biopsies. And I do hope that this talk by Dr. Andrew is going to stimulate all of us and motivate everyone to get back to doing breast FNAC as the primary diagnostic modality in the investigation of breast lumps in women. Thank you so much for choosing this topic too, Dr. Andrew. And we have, to conduct this session, we have our chairpersons, Dr. Prabal Dev, who is currently the editor of our Journal of Cytology. He's had a long experience. He served in the armed forces for over 30 years and is currently the CEO and the director of NM Medical Diagnostics. And also he'll be the co-chairperson is Dr. Sandeep Mathur, who will also act as the moderator for the Q&A session. Remember, all of you, please type in your questions in the chat box, and Dr. Andrew will be very happy to answer all your queries at the end of his talk. And Dr. Sandeep Mathur, as you all know, is Professor of Pathology at the All India Institute of Medical Sciences, New Delhi. And with this brief introduction, it's over to our chairpersons, Dr. Prabal Dev and Dr. Sandeep Mathur, to conduct the session. Over to you, Dr. Prabal Dev.
Good afternoon, everyone, and thank you for the introduction, ma'am. It is my proud privilege on behalf of the Indian Academy of Cytologists to extend a warm welcome to Professor Andrew Field. Dr. Field received his medical degree from the University of New South Wales in 1978. He completed his anatomical pathology training in 1985 and gained the FIAC in 1990. He obtained the Royal College of Pathologists of Australasia Diploma of Cytopathology in 1996. Currently, Professor Field is head of the Department of Anatomical Pathology at St. Vincent's Hospital, Sydney, and associate professor at the University of New South Wales and Notre Dame University Medical Schools. He is currently the president of the International Academy of Cytology and a foundation member of African Strategies for Advancing Pathology, which is an organization that aims to advocate for and coordinate improvements in pathology services throughout Africa. Dr. Field has committed his career to fostering the development of cytopathology in the developing world. Since 2007, with the assistance of local organizers, he has run and taught at 22 four-day-long FNAB cytology tutorials in sub-Saharan Africa and 5 tutorials in Southeast Asia with Dr. William Jeddy of Toronto and Dr. Matthew Zerka from the Mayo Clinic, as well as other colleagues, including Dr. Martha Pittman from MGH Boston. He has been a faculty member of 6 IAC tutorials around the globe and an invited speaker at numerous international meetings. Dr. Field has published more than 65 articles, 19 book chapters, 2 textbooks, including Practical Cytopathology, a diagnostic approach to FNAC cytopathology, which is very well received the world over. Professor Field has had a long interest in the establishment of international standardized reporting in FNAC cytology and has contributed immensely to the Papinicular Society Pancreaticobiliary Guidelines, the Milan system for reporting FNAC of salivary gland, and the IAC Yokohama system for reporting breast FNAC cytopathology, published in early 2020, which he would take us through today. In May 2020, he was appointed as a standing member of the inaugural WHO Cytopathology Editorial Board for the development and publication of a series of international reporting systems on the cytopathology of lung, lymph nodes, pancreaticobiliary, and soft tissue pathology. Now coming to an interesting facet of Professor Field, as is said that all work and no play makes Jack a dull boy, but for Professor Field, this was very different. He has nurtured his passion for soccer, and he recently retired as the football coach of his university team and has been awarded the Australian Sports Medal. With this, I would request Professor Field to kindly deliver his talk for the day.
Well, thank you very much. First, I'd like to thank the Indian Academy of Cytology for inviting me to give this talk. It's a difficult time for everyone, I think, in the world, and given the opportunity to present to a very large number of Indian pathologists is a great opportunity. So thank you very much. I'm just going to share the screen here. Okay, so I'm going to talk about the International Academy of Cytology Yokohama system for reporting breast cytology and the development of other international systems. So what's actually been happening? Well, the IAC Yokohama system for reporting breast was published in 2020. Fusion cytology was published in late 2020. A lymph node fine needle biopsy cytology group published a proposal on Acta Cytologica last year. And in early 2020, the IAC signed a MOU with the WHO and its publisher, IARC, to develop and publish 4 new international systems of reporting lung, pancreaticobiliary tract, lymph node, and soft tissue cytopathology. And that process has commenced. The aims of that project are to promote the use of cytopathology using standardized nomenclature and effective reporting systems that link categories in cytology reporting and specific diagnoses to diagnostic and management algorithms. These assist clinicians to manage patients. Obviously, you need to establish key diagnostic criteria that will lead to better quality diagnostic assessment and reporting of cytopathology in lung, pancreas, lymph nodes, and soft tissue. This will then be linked directly by the website to the WHO tumor classification blue books. And this will bring a dynamic practical link between cytology and surgical pathology. We hope this will raise the profile and promote the use of fine needle biopsy cytopathology by increasing awareness of its current diagnostic role and its potential role in the era of personalized medicine, which of course is based on molecular pathology utilizing small biopsies, including fine needle aspiration biopsies. Ultimately, we want to improve patient care and outcomes through the use of cytopathology internationally in developed and low middle income countries. So we signed the MOU. IARC is a specialized agency of the WHO. It aims to promote international collaboration on cancer research, foster education and training of cancer researchers worldwide, prioritizing those in low and middle income countries, and to develop and publish the WHO classification tumor series, the blue books, which are on all of our shelves. The IAC is a scientific non-profit organisation of cytopathologists, technicians and other professionals promoting the practice and research into cytopathology. The MOU covers a period of 2 to 3 years, the development of 4 systems. The key part of the agreement is to promote use of standardised nomenclature and diagnostic criteria in cytopathology internationally, and utilise cancer cytopathology expertise to develop international reporting systems. So myself and the General Secretary, Fernando Schmidt, we had been involved from 2016 in bringing together 3 groups in lung, lymph node and soft tissue cytopathology with the aim of developing international reporting systems. And then we became aware that the pancreas system of the Papua-Nicolau Society of Cytopathology was under review. Discussions were started within these groups, presentations were made at various meetings, symposia were held, feedback was gained, and then the lymph node published a proposed system in Acta Cytologica. Our aim was to find a publisher who would be involved in the process and support the publications, which would be prepared and published in a uniform way. Each system and publication would not have to reinvent the wheel. Why connect with IAC and WHO? Well, IAC is a publishing house, highly reputable, extensive experience in producing international classifications of tumours, along with a whole array of other publications for the WHO. It has an established system for the selection of editors and authors who then work collectively, seeking to establish a consensus in expert editorial boards on each system and book. And of course, it's based on expert assessment of published evidence, and then the expert opinions of those expert editorial boards. IARC has an excellent web-based database system for displaying contents and templates, uploading and then editing text, photos and tables. And it allowed for a common approach to all 4 systems. So what else has been happening besides that connection with WHO? Well, there have been a number of recent surveys, and these are really based on a survey which was held for the IA system for reporting breast cytopathology. That was hosted on the University of Wisconsin website in 2019. Our thanks go to Dan Kurtix and his team at Wisconsin University. We've published an analysis of that survey in Cancer Cytopathology, and subsequently there's been surveys on lung early this year and pancreaticobiliary. Now this closes on February the 28th, just a few days away. And these are all on the International Academy of Cytology website. We've widely publicised them through societies in the community. So far for pancreas, we've had more than 300 responses. And we really would like to encourage all those who report pancreaticobiliary cytopathology to do the survey. It's quite essential to have this information, which will then inform the expert editorial board in pancreas in developing their reporting system. Only takes 20 to 30 minutes, and it has details and provides both a snapshot of current usage and has many questions on the proposed system. And that's the link at the bottom of the page. And it'll be on the survey till the end of this week. Sorry, the next survey will be lymph node, and that will be on the website within a week's time. A soft tissue survey is being developed. And of course, it includes demographic and current practice questions. They will build a snapshot, if you like, a before and then the after, but this will be the before snapshot of the use of fine needle biopsy in lung, pancreas, lymph nodes, and soft tissue. Further questions obviously relate to the actual questions which have arisen during the discussions about the reporting systems. So how was the breast system formed? Because that predates this IAC WHO agreement. Well, it's in a way similar. A steering committee was formed at Yokohama at the International Cytology Congress. A proposed system was published in Acta Cytological in 2017. Editors and lead chapter topic authors were established and authors were recruited. A literature search and writing of draft chapters occurred. These were then circulated for review. Then we did the survey. A summary article appeared in Acta Cytological in 2019. And then finally, the text was published in late 2019 by Springer. We hope the system will stimulate research assessing the system and leading to improvements in patient care and revisions, and hopefully go some of the way to reversing the the push for core needle biopsies, which really emanates from mammographic screening programs. So there's the IAC Yokohama system, 22 authors edited by myself, Wendy Raymond, and Mary Ricard and Fernando Schmidt, amongst others. There's the textbook. So what were our aims? Very, very similar to the aims we have with the WHO. Produce a standardized approach, establish best practice guidelines, indications and role of fine needle biopsy, the actual technique of doing that biopsy, the smear making and how to handle the material. It uses a very precise terminology for 5 well-defined categories. There are key diagnostic criteria for each lesion, which is a very important component. And then it promulgates standardized reports and then discusses ancillary diagnostic and prognostic testing. A risk of malignancy is established for each category, and of course will be a subject of ongoing research. And this then links to a clinical management algorithm. And of course, the system, perhaps the first of the systems to recognize that the availability of local medical infrastructure will influence the clinical approach. So in the recommendations of each of the categories, there's actually 2 tiers of recommendations. So here you can see, and we've got the category on the left: insufficient, benign, atypical, suspicious, malignant. A risk of malignancy derived from the most recent literature, not the literature which goes back before the use of ultrasound and so on. And then there's a management recommendation, and then there's a management recommendation in places, low middle income countries, where they may not have the full array of diagnostic tests, such as ultrasound, mammography, core needle biopsy, etc. So this is what we're going to be discussing tonight. The members, the 22 writers, come from around the world, and it recommends a report format, starts with one of the 5 categories, using standard terminology. There's always should be an assessment of the cellularity of the slides, followed by a description of the key cytopathological features that support the diagnosis. And if you can't make a precise diagnosis, then you'll recommend that you give a differential diagnosis that is not a textbook list, but is actually starts with the preferred diagnosis. Then it has a diagnostic summary or conclusion. And the aim, reproducible, complete report that can be understood internationally and will be directly linked to recommended management options. There's a defined terminology for each category. There is no reliance on using a number. Numbers should only be used for quality assurance and research. If you oversimplify any area of fine needle aspiration, biopsy, cytology to a number, then this reduces the amount of information that we can give the clinician to the assistance of the patient. It's essential that under the category heading, the cytopathologist details the specific findings, a diagnosis, and a DD. For instance, the benign category includes cysts, fibrocystic change, fat necrosis, fibroadenomas, intraductal papillomas, which can all be categorized as benign. And the specific diagnosis is required in our setting to maximize the correlation with imaging and triple test. Our radiologists will not just accept a benign diagnosis. They want to know specifically what it is so they can correlate with the imaging, which then improves the quality of the triple test, clinical, imaging, and cytopathology. I'm going to make this point again and again during this talk. The performance of the fine needle biopsy and the making of the smears are the major source of quality assurance problems with breast fine needle biopsy cytology. It's a so-called simple test. It requires good initial and ongoing training. Often there's a lack of adequate training of procedures such as radiologists. Ultrasound is very useful for assessing palpable and finding impalpable lesions, but overuse of ultrasound has its own problems. It's not necessary when you're doing a fine needle biopsy of a palpable lesion to have an ultrasound probe, unless you want to take a picture of where the needle is. Maybe you use the ultrasound to assess the lesion and then use a freehand fine needle biopsy. Why? The keys to fine needle biopsy success are fixation of the lesion with the hand not holding the needle, so the lesion is fixed, particularly in the breast, and it's a rapid procedure. Less than 10 seconds, 10 to 15 rapid passages of the needle through the lesion. You need to minimize the dwell time, the time the needle is in the lesion, to prevent clotting. There's an old adage, wait for the material in the hub. But if this occurs, you should stop and withdraw immediately, unless it's a cyst or it's pus of something. But also, if you spend too long waiting for material to occur, to come into the hub, you risk clotting in the needle. Overuse of aspiration can cause hemodilution. I'm not talking about cysts and galactoseals and abscesses. I'm talking about when we're finally a mass lesion. It should be used lightly during and at the end if there's no material in the hub. It's the cutting action of the needle. It's the needle bevel, the tip of the needle moving in and out of the lesion that produces good material. You may need multiple passes. And if you do have a problem getting material, you should use a finer needle, not a larger, thicker needle. We recommend 22, 23, 25, or perhaps 27 gauge needles. Fibrin clotting within the needle is a major problem, particularly when radiologists are doing these under ultrasound and taking their time. They need to be rapid and get out of the lesion as quickly as possible. So here's our 5 categories. Why do we have an atypical category? Because we want to maintain the high negative predictive value of a benign diagnosis. We need a suspicious category to maintain the high positive predictive value of malignant diagnosis. The 5 categories provide risk stratification. We do not recommend the use of the term non-diagnostic. It means different things to different people. If we say insufficient and inadequate, we're saying there's not enough material for a diagnostic assessment. Some people use non-diagnostic in the sense that the fine needle biopsy, even though it might have a large amount of benign material on the smears, if it doesn't explain their imaging suspicions or whatever their findings, then they regard it as non-diagnostic. And I think this is a false approach. There's either enough material or not enough material. If there's enough material, we should call what's on the slides and then add a caveat if you wish, add a comment that if the imaging is different to what we find on the radiology, on the cytology, then we should say the cytology may not represent the lesion. But in breast work, we have lots of situations where that cancer on imaging turns out to be a radial scar and the other way around. So I don't believe in using the term non-diagnostic. So how do we define insufficient, inadequate? The sides are too sparsely celled or too poorly smeared or fixed to allow a cytological diagnosis. This is a cytological assessment, as I've just said. You need triple assessment where the smears do not explain or correlate with the clinical imaging findings. But we should report the cytology, and as I just said, add a caveat. The cytology may not represent the lesion seen on imaging. It should be a specific reason given for insufficiency, not enough material, poor quality smearing, air drying artifact of an alcohol fixed pap smear, etc. Of course, the minute something's atypical, even if there's a very small amount of material on the slides, the lesion is categorized as atypical and not as insufficient. Because there are clinical situations where a smear may be adequate, but may not have epithelial cells, which are often considered a judge of adequacy. This is so long as the findings on the cytology correlate with the clinical imaging findings. These include cyst contents, fat necrosis, lipomas, spindle cell lesions, scars. But if there's a palpable or impalpable mass lesion seen on imaging, it suggests that a minimum of 7 epithelial tissue fragments, at least 20 cells, that you can see well fixed and well seen is required. Why do we want 20 cells? Why not 10 cells like Bethesda in the thyroid? In the breast, we want to see the bimodal pattern of ductal cells and myoepithelial cells in the tissue fragments, so we need to see slightly larger cells. What causes inadequate rates to rise? The expertise of the fine needle biopsy operator is clearly one of the most important factors. Pathologists have lower inadequate rates. Rapid on-site evaluation of image-guided aspirates clearly decreases insufficient rates. Cytopathologists, if you're doing it yourself, are immediately aware that they haven't got sufficient material. And we stress that you can do 3 to 4 punctures, and that will actually decrease your insufficient rate. Of course, the direct smear maker is also vitally important. You can get excellent material, which is then ruined by the quality of the smearing and the failure to handle material quickly. And one of the classics is not putting your alcohol fixed sides directly and immediately, without even looking at them, into your alcohol for your wet fix slides. Of course, if you have a large amount of material and the Giemsa air dried slides are wet, you will get slow air drying artifact. And again, you have to have ways of getting on top of this. Warming plates, hair dryers. Of course, ultrasound gel can be a great problem, and it takes a continuing education of radiologists to try and get rid of the ultrasound gel. Of course, some lesions in the breast don't give good material. Small, fibrotic, hard to stabilize lesions, particularly when people are using ultrasounds. Lesions with a low degree of epithelial proliferation, such as sclerotic fibroadenomas. Impalpable lesions, which are accessed by ultrasound. Invasive lobula classically is said to give low yielding, low cellularity. DCIS, because it's just involving ducts, often doesn't form a mass lesion, can provide just a small target. And of course, necrotic or infarctive or suppurative lesions can obscure the epithelial component. How do you manage an inadequate smear? You need to review the clinical and radiological findings to decide whether you're going to repeat the fine needle biopsy, or if you have core needle biopsy available, you may go on to core needle biopsy. But if a smear is technically suboptimal, immediate repeat fine needle biopsy is recommended. Obviously, this relies on rows. But even if the patient's gone away from the clinic and is called back, repeat FNAC can, in many situations, provide adequate material. Perhaps a more experienced operator needs to be involved. If the imaging is indeterminate or atypical, and you're using rows or subsequent fine needle biopsy result, then of course further biopsy is mandatory. If suspicion is low, most studies showed that no further fine needle biopsy is required at that time. Rather, the clinical and imaging follow-up can be recommended. Definition of benign category: unequivocally benign cytopathological features, which may or may not be diagnostic of a specific benign lesion, such as fibrocystic change, fibroadenomas, and so on. It's very difficult in the literature to establish a risk of malignancy because most cases do not go on to surgery. But a negative clinical and or imaging follow-up at 6, or some people say 12 months, is regarded as sufficient to record the original triple negative diagnosis, incorporating the benign fine needle biopsy as correct. So these are the lesions that fall into the benign category: acute mastitis, abscess, fat necrosis, cyst, fibrocystic change, normal breast tissue, epithelial hyperplasia or usual epithelial hyperplasia if you prefer, fibroadenomas, intraductal papillomas, lactational change, so-called lactational adenomas, adenosis, and sclerosing adenosis. How do you manage a benign call? You really only require routine clinical imaging follow-up rather than any further procedures such as a core needle biopsy or excision biopsy. There's a long history of utilizing breast fine needle biopsy without imaging. For example, a specific benign fine needle diagnosis that correlates with the clinical findings such as abscess yielding pus, a cyst which fully drains without a residual nodule, or rounded firm mobile nodule with characteristic cytological features of fibroadenoma. Imaging is, in the literature, not required. But of course, we do recommend that correlation with imaging, if it is available, to achieve the triple test is best practice if the imaging is available. Atypia, well, the atypical definition: the presence predominantly of cytological features that are seen in benign processes or lesions, but with the addition of some features that are uncommon in benign lesions and which may be seen in malignant lesions. What are we talking about? What sorts of things might be uncommon in benign lesions or less common and alert us to something that may be atypical or malignant? They include such things as single intact cell dispersal, nuclear enlargement of pleomorphism, high cellularity, remembering that many proliferative lesions in the breast that are benign can give high cellularity, necrosis, complex architectural features suggesting micropapillary or cribriform proliferations. You should always describe the material present if you're going to call something and categorize it as atypical. Describe the degree of cellularity. and then state which specific cytological features make the lesion atypical. And if possible, state what the differential diagnosis is for the case. The atypical category is not meant to be a rubbish bin. Whenever we call something atypical, we should be able to say why we consider it atypical and document that. And of course, the causes include technical problems, scant material, and of course, interpretive problems related again to the characteristics of the lesion. Often it's a combination of these factors and of course, the expertise of the pathologist. So atypical, related to lesion features. Well, fibroadenomas are probably the commonest cause of atypical diagnoses in the breast. They can be due to marked hypercellularity or they can be due to low cellularity in sclerotic fibroadenomas. Some fibroadenomas will have stromal hypercellularity, and then the differential diagnosis is low-grade phyllodes. Intraductal papillomas with epithelial hyperplasia can cause atypia. Fibrocystic change with usual epithelial hyperplasia, including radial scars, can be a problem. There's a spectrum of proliferative lesions, just as we know in surgical pathology using core biopsies or excision biopsies. There's a spectrum, columnar cell change with hyperplasia, flat epithelial atypia, usual epithelial hyperplasia, sclerosing adenosis. And of course, you go on then to atypical ductal hyperplasia and low-grade ductal carcinoma in situ. That spectrum is difficult in surgical pathology, particularly in core biopsies, and it's no surprise that it can cause problems in cytology. Lobular neoplasia can often be associated with low cellularity. You can get extensive necrosis or mucin, and there are some lesions such as adenomyopatheliomas and spindle cell lesions that would almost always result in an atypical call. How do you manage an atypical call? You need to correlate with the clinical imaging findings in the triple test. And if the imaging or clinical findings are indeterminate or suspicious, in our situation, we'd recommend a core needle biopsy. If no core needle biopsy is available, then you repeat the fine needle biopsy. Or if clinical and suspicion is high, because that often occurs in a situation where there's no imaging, then you go to simple excision biopsy. If the imaging and clinical findings are not atypical, the consensus was that when we published the IAC reporting system, that review the patient at 3 to 6 months was the most common response. And that was also supported by the survey response. If no core needle biopsy or imaging is available, then the least that should be done is a repeat fine needle aspiration biopsy. Some examples. So here we've got, I think you can see my marker. We've got ductal epithelial cells with our slightly larger ductal nuclei and our myopithelial nuclei. We've got apocrine cells, we've got multinucleated histocytes and other histocytes, and we've got some classic looking bare bipolar nuclei. Benign, fibrocystic change. But here we've got getting some nuclear enlargement, increased cytoplasm, some crowding, and over here we've got apocrine metaplasia. So these are ductal cells changing into apocrine cells, which can lead to nuclear enlargement and some atypia. Apocrine cells can disperse as well. And dispersal, as I mentioned before, is one of our criteria that alerts us that we may be dealing, if we can see epithelium that's dispersing, with atypia. Apocrine cells, and you can see there's some inflammatory cells over here from an inflamed cyst, can spindle, they can undergo evacuation, and they can develop some nuclear atypia. Again, I wouldn't consider this atypical, but in certain settings, it could well be atypical. Again, now in a cyst, we can see the histocytes and proteinaceous background and some inflammation with the neutrophils. You could see the apocrine cells, very plump spindle cells, occasional vacuoles. The nuclei, which we go from one to another in this little tissue fragment or across here in this tissue fragment, do show some minor variation from one to another. The NC ratio is very low, and this is benign, but there is some nuclear atypia. Of course, you can get multinucleated cells. This is most likely a multinucleated apocrine cell again degeneration in a background of histocytes. As I mentioned before, degeneration of apocrine cells can produce quite significant atypia. We've got enlarged nuclei, multinucleation. Clearly, showing evidence of degeneration. But again, look at the vacuoles. Vacuoles do not mean malignancy. These are apocrine cells showing degeneration and some degree of atypia. We know that as we approach the tail end of smears in any highly cellular lesion, such as a fibroadenoma, that our large ductal epithelial cell tissue fragments with myoepithelial cells can show a degree of crush artifact and dispersal. So we get some minor nuclear changes. We've clearly got good quality bare bipolar nuclei in the background, and we've got some chromatinic nuclear streaming, and we have a fair bit of debris. But seen by itself as one field, this could be regarded as atypical till we take into account the full the full picture of the direct smears. What about columnar cell change with these large ballooned terminal ductules? This is not a papilloma, or not a papillary structure. This is actually a ballooned terminal ductule. And you can see this proteinaceous material in the background. And here you can see the myoepithelial nuclei on the surface of this balloon terminal ductule. And over here, as we go down, probably the lobular duct. So this is columnar cell change. And of course, it's frequently associated with calcifications. What about this? Well, you can see there's a basement membrane around these terminal ductules. And this is actually a lobule which has been ripped out by the aspiration, by the fine needle biopsy. And these are not micropapillae. These are actually the terminal ductules of a lobule. Here again, we can see the lobule with its basement membrane around the terminal ductules. And on the right-hand side, we can see these terminal ductules, which in this case do not have clearly defined basement membrane, but these are not micropapillae. These are actually a lobule. And when we get usual epithelial hyperplasia, we've got these fairly evenly spaced nuclei and the very obvious myoepithelial nuclei. But in some areas, it becomes more complex. After all, it has come from a duct where it was three-dimensional. One can't accept, we have to accept the fact that not all ductal epithelium is going to cause flat sheets. It is going to cause some complexity. And it has these ragged secondary lumina, these ragged holes with the nuclei streaming around them, good quality myoepithelial nuclei, a bimodal pattern with the ductal cells. This is totally benign, but some people may regard it as atypical. Again, you can see the streaming of the nuclei around this defect or hole, and we've got our myoepithelial nuclei, usual epithelial hyperplasia. But in some situations, and this comes from a fibroadenoma, you can get nuclear enlargement and atypia, an increase in NC ratio, and this can be a worry. And I would call this atypical. And it's particularly when we juxtapose it to the bottom left-hand side of the picture, where we can see very uniform ductal epithelial nuclei. But certainly this would be atypical coming from a fibroadenoma. Sometimes lobules with their specialized stroma and the terminal ductules can become disrupted and could lead to a differential diagnosis of intraductal papilloma. So again, some further examples: cellular fibroadenomas versus low-grade Phyllodes tumors. Here you can see that this looks quite thick, three-dimensional. It's got capillaries run through it. But down on our right-hand side, you can see where the tissue fragment is flattened out, and we don't really have any degree of hypercellularity. And these are normal, small stromal nuclei, which of course do show some irregularity and pleomorphism of size and shape, totally normal. So just to repeat that, we have to be very careful of calling high stromal cellularity and atypical when we can see other areas where the cellularity is not as marked. Oh, what's happened? Sorry, I've jumped through. I'm not sure why that happened. My apologies. 1 minute, please. So that's our fibroadenoma. And in this case, we can see a more uniform hypercellularity of the stroma. The epithelium is typical of a fibroadenoma or a low-grade Phyllodes. But here the stroma is quite hypercellular uniformly right across the tissue fragment. And here we can see nuclei upon nuclei. It's a little bit crowded. We're getting a minor degree of nuclear enlargement and quite significant nuclear variation, shape and size within this stroma, even as we approach the margins of the stromal fragment. And you may see more plump spindle cells in the background. So this would suggest that we're dealing with a low-grade Phyllodes tumor and would be categorized under the IAC system as atypical. What about fat necrosis? And we see a fair bit of this now because women are having wide local excisions and coming back with nodules in their breast in the scar. So we can have large fragments of fat tissue. Here are the adipocyte shells, lacking any nuclei, just leaving the cell margin. And some cases of fat necrosis, we just see this multicolored granular material, some of it vaguely reminiscent of degenerate cells. And we're quite happy to call this fat necrosis and correlate with the imaging. Adenomyophtheliomas with their two-cell type, their epithelial cells, and then the magenta-colored stroma. And here we can see the spindle cells of the magenta-colored stroma and the epithelial component, which in some areas is streaming and spindle and other areas is more polygonal. And sometimes these can present just with spindle cells, and it's hard to recognize the epithelial component. Spindle cell lesions of the breast, relatively uncommon. Here we've got this relatively uniform stroma. We've got small spindle cells within that, very ragged, irregular margin. And in some areas, again, we can see the fibrillary collagen tissue and these relatively uniform small nuclei of the stromal cells. Recognizable when taken into, correlated with the clinical imaging finding as a fibromatosis. Again, this fibrillary collagen, a large amount of collagen separating these relatively uniform stromal nuclei of a fibromatosis. Nodular fasciitis, if we're not told where the lesion has come from, and it's just labeled as a breast FNA, can be quite a problem, but they form these areas of myxoid stroma. They have plentiful spindle cells in the background, and they often have these 1 or 2 or 3 multinucleated cells in the background. Again, multinucleated cells, a little bit of variation, but most nuclei show a similar chromatin pattern and a similar oval nucleus within the spindle stroma. Suspicious of malignancy? Well, it's defined as the presence of some cytomorphological features which are usually found in malignant lesions, but with insufficient malignant features, either in the number of the features or the quality to make a definitive diagnosis of malignancy. You should always say in your report the type of malignancy suspected, rather than again using this as a rubbish bin of diagnoses. Risk of malignancy is 81 to 88% in the literature, and it maintains the high positive predictive value of a malignant breast call. Of course, technical limitations, interpretive problems, limitations in the specimen quality due to low cellularity, thick or blood-skewered material, crush artifact, air drying artifact. And of course, the expertise of the cytopathologist plays a significant but smaller role in producing high rates of suspicious of malignancy. Of course, the inherent nature of some breast lesions, as we've just discussed with that spectrum of proliferative breast disease in the breast, and an overlapping of cytological criteria for benign and malignant tumors can cause problems. Low-grade ductal carcinoma in situ and high-grade ductal carcinoma in situ were the subject of a lot of the discussion within the writing group. As I said, the differential diagnosis in cytology between proliferative disease and low-grade DCIs is challenging. There are some overlapping diagnostic criteria. Low-grade DCIs, of course, usually presents as calcifications and rarely presents as a clinical mass. So it's an uncommon fine needle biopsy diagnosis, particularly if you're not servicing the assessment clinics of a mammographic screening program. But when we have features that do suggest low-grade DCIs, we should try and recognize them to avoid the overdiagnosis of malignancy on the one hand, and the underdiagnosis or undercalling of ductal carcinoma in situ as a proliferative breast disease. So we're not studying low-grade DCIS so we can make specific diagnosis, because this is difficult. And also when we have surgical pathology, we know that we'll have great variation across a slide in surgical pathology, where we'll have usual epithelial hyperplasia in one duct or one complex of lobules. We'll have atypical ductal hyperplasia and low-grade DCIS. And as we cut through the block in surgical pathology, those features may change. So we know this is a difficult diagnosis, but we want to try and learn about it so that we can suggest the presence of low-grade DCIS. So we don't call something malignant on the one hand, and we don't call these lesions proliferative on the other. It's recommended that in cases suspicious of low-grade DCIS on cytology, give a diagnosis of suspicious malignancy and raise the possibility of low-grade DCIS. So we avoid a false positive malignant diagnosis, which is really crucial to our fine needle biopsy breast service. And you can recommend core needle biopsy or excision biopsy. High-grade DCIS, again, is usually found, if it's by itself rather than just associated with a cancer, it's usually found on mammographic screening programs. If we see extensive necrosis with calcifications and low cellularity on direct smears, but the low cellularity is made up of cells which are highly atypical, and we may see some small tissue fragments of crowded, similar, highly atypical cells, then we can suggest the presence of high-grade DCIS. Now, necrosis can be seen in some high-grade invasive cancers, particularly basal-type carcinomas, triple-negative carcinomas, high-grade, grade 3 carcinomas, no special type. But if we suspect high-grade DCIS, the IAC system suggests the use of terms of suspicious of malignancy, and should have a phrasing which raises the possibility of carcinoma is present with features suggesting a high-grade DCIS component. So again, we're not trying to make the diagnosis of high-grade DCIS to the exclusion of malignancy, but we're trying to suggest its presence. And again, that will then go back and be correlated with the imaging and clinical findings. Of course, many of these cases will be called malignant, so there's a need to correlate with the imaging. The question then arises, can we diagnose absolutely the presence of invasion in fine needle aspiration biopsies of breast lesions? This is highly contentious at present, but in the past, we were always taught that fine needle biopsy cannot dogmatically make a diagnosis of malignancy in breast cases. Some of us would suggest that we can. Anyway, the outcome is that core needle biopsy should be recommended. Follow-up biopsy is mandatory if we make a diagnosis suspicious of malignancy, irrespective of the triple test, the imaging and clinical findings. If you have core needle biopsy, then this is where we recommend it should be used. But you may come to excision biopsy, even if you have core needle biopsy, to exclude invasive cancer. And if you don't have core needle biopsy, a suspicious malignancy call on cytology should lead to an excision biopsy. If that call is made at Rose, the clinician can discuss the triple test findings with the patient, immediately proceed to core needle biopsy, counseling and discussion with the patient, and discuss and start to organize the management, all happening in that setting. If the suspicious malignancy diagnosis is issued sometime after the fine needle biopsy, then the cytology, the imaging findings form the base of discussion with the patient. And of course, core needle biopsy or excision biopsy is the usual follow-up. So what about this? Here we've got a large tissue fragment. It's complex. It's got these punched out holes, and it's got some apoptotic debris. This is another problem we sometimes face. We can see this apoptotic debris on the surface, and it can mimic myoepithelial nuclei. But you can see that these punched out holes, they're frequent, the larger number, and the nuclei tend to orientate at right angles to these punched out holes. Now on Giems's, air-dried material in Giems's, it can be very difficult to make a diagnosis or to suggest that we've got a cribriform architecture. But again, we see the nuclei around these punched out holes. They're very numerous. Again, the nuclei are orientating to the hole. And if we see this feature, particularly if we see it in multiple tissue fragments across a cellular smear, we are able to suggest the possibility that we may be dealing with a ductal carcinoma in situ component. Here again, at high power, nuclei orientated around this punched out hole. What about micropapillary architecture, where we have a narrow neck and a rounded head? And as we look through here, we get crowding, some mild to moderate, in this case, nuclear atypia. We can suggest a micropapillary architecture. I would contest very strongly that we can call a micropapillary architecture, doesn't have the features of a lobule. This micropapillary architecture, it's a very, in a sense, straightforward diagnosis to make and suggest the presence of DCIS, low grade, possibly intermediate grade, against a stellate fibroelastotic stromal fragment with epithelium attached. And we can go down and check this epithelium out, look for myopithelial nuclei. This is from an intraduct papilloma. This, on the other hand, with this branching well, it's really a vascular core. I should call it a fibrovascular core. And you can see the orientation of these quite tall columnar cells on this. And it's in a background of massive dispersal of intact cells. In some situations, you can see the fibrovascular core and then the rounded end of the capillary. So we're actually seeing the rounded end of the capillary. And again, large numbers of dispersed cells in the background. Again, a fibrovascular core, a columnar orientation along it, dispersed cells in the background, not showing any marked nuclear atypia, but the architecture of these fragments would suggest that we're dealing with a papillary carcinoma. And the most common papillary carcinoma is ductal carcinoma in situ. And of course, we can get dispersal, and now we're getting a sense of some of these have moderate to high NC ratio, some of them are columnar, and there's a degree of nuclear atypia. This is a special circumstance of a papillary ductal carcinoma in situ. This is solid papillary carcinoma, I should say. Here you can see the rounded capillary loop, and it looks like a glomerulus. If any of you are doing renal biopsies, this looks like a glomerulus, and these red structures, these are actually red cells within the capillary loops. It's a little bit easier to see on the PAP. Here we've got the fibrovascular core. Here we can see it goes out into little blunt ends, just as we know the little fibrovascular papillae go out into a solid papillary DCIS. And here we can see these endothelial cells lining these capillary loops of this solid papillary DCIS. Here are the endothelial cells. And in the background, we're now getting moderately atypical cells here at high power. Again, you can see the endothelial cells lining these capillary loops, quite distinctive in my mind for solid papillary carcinoma. What about where we do have necrosis and we can see calcifications and we can see small numbers of epithelial cells, and quite clearly these have got large nuclei, overlapped, crowded tissue fragments dispersing in the background, calcifications, necrosis, and high-grade cells. We should suggest the possibility that we may well have a high-grade DCIS component. We cannot exclude the presence or absence of invasive cancer in this situation. But what about this? Here we have a desmoplastic stroma. We have epithelium, which even at this power, I think we can say is malignant. And this tissue fragment is actually extending into this desmoplastic stroma. Here's seen at high power. The epithelial cells, I would suggest, are infiltrating into this desmoplastic stroma. This is like a small tissue fragment that we see from some core biopsies, at least in our practice. We see the core biopsy and we can make a diagnosis of invasive cancer. Well, you can see exactly the same situation here in this fine needle biopsy. Here again, we've got magenta colored stroma. We've got the epithelial cells infiltrating into it in the same plane. And adjacent to this, we've got clearly malignant cells, and these cells within the stroma, again, constitute invasive cancer. What about a situation like this where we've got uniform high cellularity right across the tissue fragment and we've got our small epithelial fragments? And I think you can see there's large numbers of single cells in the background. At least some of these are spindle. This is where we'd use suspicious of malignancy, where we'd be referring to a high-grade phyllodes tumor. And again, now we're getting very significant nuclear atypia and crowding, variation, shape, and size. We would call this suspicious of malignancy and specifically query high-grade phyllodes tumor. So we say the malignant definition where there's unequivocal statement that the material is malignant and the type of malignancy identified should, if at all possible, be stated. You should only make a malignant diagnosis when there's a constellation of diagnostic criteria with no discrepant findings. None of the criteria, as we've discussed, of high cellularity, marked dispersal, or nucleotypia is individually diagnostic invasive carcinoma. And these features individually can be seen in proliferative and intraduct lesions. The positive predictive value of malignant breast fine needle biopsy diagnosis should approach 100%, and it should be based on adherence to specific cytological criteria for carcinoma and any other lesions applied by the cytopathologist. False positives are very rare in the literature and usually due to errors in interpretation of proliferative breast lesions, usually intraductal papillomas, fibroadenomas, and adenomyoepithelioma. False negatives frequently have minimal material when reviewed or only benign elements, suggesting inadequate sampling is the major cause. And the first thing I do when someone brings a case back to me of a core biopsy or excision biopsy where we've made a malignant diagnosis, and particularly in the core, and they say there's no cancer in the core, first thing you check is what location in the breast, what o'clock, how many centimeters from nipple the core biopsy was taken, and equally the fine needle aspiration. They must correlate. They must correlate before we can really go on to assess whether we've got a false positive. Discordant triple tests, for instance, a malignant fine needle biopsy in a case of benign imaging or clinical findings, require further investigation prior to definitive treatment, usually a core biopsy. So we have our carcinomas that fall into this category, various carcinomas, and of course, here we have the less common carcinomas, secretory carcinoma, we very, very rarely see in Australia, adenoid cystic, glycogen-rich, histiocytoid carcinoma, which I think now is basically accepted as being lobular cancer, and of course, non-Hodgkin's lymphoma and metastases. Metastases really is an issue in younger women. How do you manage a malignant cytological diagnosis? It requires further workup, including core needle biopsy or excision biopsy. It's mandatory. If the fine needle biopsy diagnosis does not correlate with the imaging or the clinical, then core needle biopsy is required. If it's not available, further fine needle biopsy, or in most cases, excision biopsy is mandatory. So these are the aims of the breast IAC reporting system, a comprehensive standardized approach to breast fine needle biopsy, and to establish best practice guidelines covering indications, the role, the technique of fine needle biopsy, smear making and material handling are very important key elements of what the breast group was trying to achieve. We then use precise terminology for categories that are well defined. We use key diagnostic cytopathological criteria for lesions in each category, which again leads to standardization and improvement in reporting. And we produce standardized reports that are uniform and reproducible, and use ancillary diagnostic and prognostic testing as appropriate. In the breast, it's ER, PR, HER2, often done by FISH, ER and PR by immunochemistry on cell block material, and the FISH can be done on cell block material, other cytological preparations. And we use Ki-67 fairly extensively, but we can also do e-coherins and cytokeratin 5/6 for basal type tumors and so on. The risk of malignancy for each category is established, and it's increasingly, that's where the literature is looking at this, and the number of papers is increasing using the IAC system in breast work to assess it, whether it works, to try and establish, again, the risk of malignancy of each category. And the categories are linked. The categories are linked to clinical management algorithms while recognizing Again, to emphasize this, local medical infrastructure may vary. So we have 5 defined categories directly linked to management recommendations. Clinicians won't use a system unless it assists them in how to manage the patient, what to do next. Management options depend on local infrastructure. So the system recognizes that, so it can be used internationally. The key cytopathological criteria, we hope will lead to improved interpretation of breast smears, and hopefully, and this is what's happening, it's generating retrospective and increasingly prospective studies. We recommend use of ROSE not only in breast, but in all fine needle biopsy cytology. It reduces inadequate rates, it increases specific benign and malignant diagnoses. It facilitates cost-effective triage, including the decision when to perform a core needle biopsy. And most importantly, it provides a provisional diagnosis that facilitates patient care and reduces patient anxiety. This is Bondi Beach in Sydney. I'm sure you've heard about it. The Sydney Cricket Ground is about 3 miles inland from Bondi Beach. This is part of the Sydney where I at least grew up in part. Thank you very much.
Thank you, Dr. Andrew, for this excellent talk. I think when people talk about breast cytology, there are a lot of questions which come to the mind, since we all are aware that core needle biopsy is the preferred modality these days, especially the modality of choice by our clinicians. But I'm sure, especially in the low resource countries and in India itself, we have had a lot of cytology being done in the past on breast lesions. So it was really interesting and it was very, the guidelines issued by give us, I think it will instill some confidence in classifying the lesion and bring about a uniformity in the classification of breast lesions. Your talk was very well attended, sir. It was around, we had close to 300 people watching this right now. We have 235 people logged in. And there's a lot of interesting questions which have come up. And if you permit me, I'll just take up one by one some of the related queries. So I'll begin first with Dr. Radhika, our secretary itself, who has asked that how can we convince the clinicians to get upfront FNA done in place of core needle biopsies in patients with palpable breast lumps, as was the practice in the past? And can IAC play a role in the formulation of guidelines for clinicians? There is also a related question which I will straight away take up, that is by Dr. Mehrbano Kamal, who's also an active member of our academy. Does this new system propose or accommodates the policy that clinically and radiologically benign lesions must undergo FNA as a first-line investigation instead of core biopsy? Is that the recommendation of the
Absolutely.
guidelines?
Okay, so let's address this. If clinically something's thought to be benign, and if there's imaging saying something's benign, then fine needle biopsy should be the first step. There are a lot of I should go back a little bit here and say most of the recommendations which are coming out of the UK and North America really relate to mammographic screening programs and a situation where mammography is often the modality which has made the diagnosis. In that situation, mammography is going to emphasize masses and calcifications. If you're dealing with calcifications without a mass lesion, then we would totally recognize that core needle biopsy is the first test. If you've got a mass lesion, we believe it should be a fine needle biopsy, and it's contentious. And I recognize that the NHS in England and various groups in America say that no, you should only use core needle biopsy. I think it's a total waste of resource. A core needle biopsy in our environment may cost up to $400. A fine needle will be around about $100. Now, the question about whether or not it should be the first modality used, I mean, there are obviously situations in breast work, if you're dealing with something you think is a cyst, if you're dealing with something you think is an abscess, if you're dealing with something you think is a fibroadenoma, in all of those circumstances, if it's a palpable lesion, the first test should be a fine needle biopsy. And in our environment, yes, we would have imaging, but you don't really require imaging. I think there's a long history going back to the 1970s of using fine needle biopsy on palpable lesions in the breast with great success. And the difference between that and the core needle biopsy, I think in some circumstances, the core needle biopsy is totally inappropriate. Putting a core needle biopsy into an abscess, putting a core needle biopsy into a cyst, putting a core biopsy into a woman who's got a lactating breast, I think is contraindicated because of the various risks. And you're much better off using a fine needle biopsy, making a diagnosis. If you have a situation where you come up with something that is atypical, you can then plan what you wish to do. And I come back to it. Fine needle biopsy is most powerful when we put it together with rapid on-site. Now, finally, the IAC is an International Academy of Cytology, which is dedicated to teaching and the promulgation of cytology. It is not a political organization. We still feel strongly that by putting out an international reporting system, that if we can encourage people to use it, it will actually improve the quality of breast cytology. That's one element. But it also, I think, will establish the fact that you can use you can use fine needle biopsy in breast work very, very effectively. And the more articles and the more research we have, the more prospective studies, using our key diagnostic cytological criteria, using our structured reporting, using our recommendations, the more clinicians, I believe, will use us. I do think, though, in our situation, we can use fine needle as a diagnostic test, but also ultimately a triage for cases which need core needle biopsy, which saves money. It saves money. And that should be one tack that we should take with our hospitals and our clinical friends, that given the right circumstances, and I work in a clinic 5 days a week, we do this, they do the fine needle, they do the imaging, the clinical, they use fine needle biopsy, we're on site, we give a rapid on-site evaluation, and decision then is made to go on to core biopsy. And finally, I want to make a comment, this wasn't the subject of this talk, but we commonly use fine needle biopsy for palpable lymph nodes. And if the lymph nodes are seen on the imaging, we'll also do a fine needle biopsy, not core biopsy in the axilla. Our patients, of course, go on to sentinel lymph node biopsies, but a positive fine needle biopsy obviates the need for that. And again, saves money, saves theatre time, saves surgeons time.
Absolutely. I totally agree with you, sir. And there was also, since you already talked about the FNAC of axillary lymph nodes, there was a question related to that. Also, should we habitually do concomitant FNA of the axillary node in case there is a palpable lump in the breast along with the axillary node, which is also accessible?
I was taught as a medical student, whenever there's a breast lump, that I then examine the lymph nodes.
Yes.
So if you do an ultrasound of a breast, or you have if you have a mammogram, sometimes lymph nodes will be seen on the mammogram. But if you do an ultrasound of the breast lesion, you should automatically do an ultrasound of the axilla. And I'm not saying you have to use an ultrasound to do a fine needle biopsy in the axillary lymph node, but again, it may assist. That should be automatically part of your protocol. If you take an ultrasound, examine the breast, you should examine the axilla. And if you find a mass, then you should do a fine needle biopsy.
Question by Dr. Cool. I don't know what is his real name, but sir, will you please elaborate on best practice recommendations in diagnosing breast lesion where triple tests along with ancillary studies is not economical, he says. So it probably means, should we do a breast FNA in such a setting at all when we don't have available imaging findings, etc. Yeah. And we can't do any ancillary tests?
Well, I'd like to point out that, in the 1960s and 70s, when they were developing fine needle biopsy in Scandinavia, they didn't have mammography. They didn't have ultrasound. If there was a palpable lesion, they put a fine needle into it. And as time's gone on, now we have imaging. So we would routinely do imaging prior to a fine needle biopsy. But in some circumstances, particularly if you don't have imaging, I think fine needle biopsy of a breast lesion is an eminently, highly suitable test to do as your first diagnostic test. If you don't have imaging, breast fine needle biopsy is incredibly powerful. Yes, you can only do lesions which are palpable, obviously, but you are advancing care, breast care in women. I would suggest massively if you just use fine needle biopsy on palpable mass lesions. That's how fine needle biopsy of breast began, and I see it as an absolute boon in a situation where you're trying to decide what's going on in a woman's breast.
There was another question, in fact, a comment by Dr. Amit Adhya. He says that many cytologists habitually write biopsy for confirmation within codes. including inducing the belief amongst clinicians that FNA is not confirmatory. So moreover, he also adds that biomarkers are not done on FNA material routinely, encouraging clinicians to go for biopsy. So any quick comment on that, sir?
Well, I think it's in the literature that using cell block material from fine needle biopsy of breast is just correlates very, very well with core needle biopsies. In fact, a couple of studies over the last 3 or 4 years have shown that it's not only just as good, but perhaps even better because the material is less crushed. So I think using cell blocks routinely in breast work, if you don't routinely do core needle biopsies, a cell block, if you can do it, is a very, very simple procedure. And it gives you a surgical specimen which can be processed and all your prognostic indicators can be done on it. If you're going to do, I only comment on that, is that if you're going to do HER2 on cell block material on breast cancers, then you will get some edge effect. And we routinely don't do that. We would use ISH. We'd use CISH in our environment. So ERPR would be done just on the cell block material. And if you get sufficient material, and most good operators doing a fine needle biopsy of breast can get good material, even if they have to put a third pass directly into the formalin or directly into whatever their transport medium is to get the cell block. So yes, you can do it. It's in the literature, and it's just as good as using a core biopsy.
Yeah, so I think that also answers another question which was put up by one Dr. Seema. So about regarding ERPR, HER2 and FNAs. So what about smears? As far as cell blocks go, it is fine. But suppose you are not able to get a cell block and you have a cellular smear. Would you recommend doing it on a smear?
I don't have experience of doing that because in our environment, we either use the cell block or we triage and the cancers will then have a core needle biopsy. Okay. And we do most of our ERPR work on the core needle biopsy because we can afford it. And by using the FNA with rows to triage, we just reduce, as I said, our cost by about 2/3, reduces expenses. But I have no experience of doing ERPR personally directly on direct smears. I know you can do ISH on direct smears. You can do ISH on liquid-based cytology preparations from the breast, but we don't routinely do that in our environment. In the literature, I believe you can destain and do ERPRs on direct smears, but it's not something we do routinely.
Okay. Then there was one question by Dr. Jayalakshmi. Sir, how can we confidently report invasive breast carcinoma in a cytosmear? A case of comedo high-grade DCIS can also give such appearances. Isn't it true?
Okay, so I tried to present the fact that when we have necrosis and calcifications and we have low cellularity, then that would be a scenario where, particularly if we cannot feel a mass lesion and calcifications have been found on the mammogram and the ultrasound and the clinical examination do not show a mass lesion, and then we get necrosis, calcs, and high grade, but not very cellular material, then we would say we would actually go as far, having done the correlation with imaging, and say the features of a high-grade DCIS with or without an invasive component. So if on the other hand, we've got a mass lesion that we can palpate or see on imaging, and it's got typical casting calcifications of a high-grade DCIS within the mass or adjacent to the mass, and we've got necrosis calcifications and usually much higher cellularity, then we would say this is cancer, this is carcinoma, and we think there will be a high-grade DCIS component. I think I've tried to explain that there's a difference. We cannot ever categorically, when we see necrosis, calcs, and high-grade epithelium, say this is categorically high-grade DCIS. That's why we go to surgical biopsy and excision biopsies of these lesions, because they are often upgraded to cancer. But it may well influence how a case is managed by the clinicians. So we try and be as precise as possible. Now, in general practice, if you don't have imaging and you got a mass lesion in the breast, you do a fine needle and you get necrosis, calcs, and epithelium, you're going to call it cancer because you're unable to correlate. You're unable to correlate. I showed you examples of situations where we get tissue fragments which are stroma and clearly infiltrated by cancer, just like we see small fragments in core biopsies. So in that scenario, I believe we can say this is categorically malignant. But that is a contentious issue at present in the literature. It's again, because we created a reporting system, we hope that there will be prospective studies to try and elucidate these sorts of issues.
And there was one more question I'd like to take up by Dr. Ruchika Gupta. In case cyst fluid is aspirated and radiological findings are not available, is it that the absence of epithelial cells should be disregarded or case reported as inadequate? In case the radiological findings are not available, it's a cyst fluid which is only aspirated. No epithelial cells.
So going back to the 1970s and early 1980s, when I trained in cytology, the approach in Scandinavia was that if you have a palpable lesion in the breast and you put a needle into it and you drain 2 mils, 5 mils, 10 mils, whatever it is of fluid, and the lesion, there's no residual lesion that can be palpated. This is before the days of ultrasound. There's no lesion that can be palpated. And you make your smears and you see a proteinaceous background with histiocytes. It's quite reasonable to say the features are consistent with cyst contents. If you see apocrine cells in addition to the proteinaceous background and histiocytes, and there's no palpable residual lesion, you're quite within your rights to say, and quite sensibly to say, this is a cyst. So you don't need to have epithelium when you've got a palpable mass and it drains away completely. You don't need epithelium to be able to say this is sufficient. Now, in the world of ultrasound, you can put an ultrasound probe on and you can do your fine needle aspiration and drain a cyst, and it's very dramatic. You can actually watch as the cyst collapses down. So that just accentuates our ability to say, well, look, that's a cyst, and you don't need epithelium within it. So I know Bethesda Thyroid 1 said, you know, if you get proteinaceous material and some histiocytes and some pseudophages from a thyroid cyst, they regarded that as insufficient. I don't think in breast work that has ever been shown to be true. We can call this benign, cyst contents, or a cyst. If there is a residual mass and we put a needle into it and we get the change, the fibrocystic change, I think we're equally sound to be able to say the first aspirate fine needle biopsy was a cyst. I hope that answers that question.
Yes, thank you very much. And there was another question which I had regarding nipple cytology. Sometimes our clinicians, surgeons, especially friends, are especially very fond of sending us patients who are having some nipple discharge, either bloody or serous discharges. And we find it really difficult when you see these epithelial fragments. What kind of a guidance you can give them regarding that? So any comment?
Well, there is a chapter in the book on nipple as nipple fluid, but in my experience, I don't find nipple fluid, making smears particularly useful. The vast majority of them, like I've only, I think, seen 1 or 2 cancers in my whole working career that were suggested, not diagnosed, but suggested on direct smears of nipple discharge. Yeah, I mean, in my environment now, if there's no palpable mass that you can put a fine needle into, yes. And I haven't touched on it much tonight, but intraductal papillomas, we published on in 2006-07, and we feel very strongly that we can diagnose an intraductal papilloma. Yes, people will go on, if there's a nipple discharge, to doing a simple excision of the nipple. And I think that's the way to go. If there's a mass lesion that you can palpate, you put a fine needle into it. If there's a lesion you can see on an ultrasound, you can put a fine needle into it. And that is a far better way of trying to decide whether or not a nipple discharge involves intraductal papilloma, possibly and relatively uncommonly intraductal carcinoma. And of course, not really ever carcinoma. So in terms of nipple discharges, I think if there's a mass lesion, you're much better off putting a fine needle biopsy into it. If someone's got a bloody nipple discharge and you have to do something about it, you can do your touch preps of the nipple discharge. But in my experience, they don't yield much. The cells round up, they become degenerate, they look papilliform, and often that degenerative changes can make them look atypical. I don't find it very useful.
Another question which I had was regarding these spindle cell lesions if you get in the breast aspirate. Now, is it really possible to confidently categorize a benign phalloids versus, say, a borderline? Of course, when there are frank malignant features in a spindle cell, you will tend to think of a malignant phalloides tumor. But what about what is the best way to report a lesion where you really can't differentiate a benign phalloids from, say, a borderline kind of a lesion?
Well, I think the borderline tumors, I showed a couple of examples with high cellularity, a mild, moderate degree of necroatypia, pleomorphism. They're not really the issue in my experience, because those are clearly we're going to call atypical. And then your high-grade phalloides, in my experience, just look like sarcomas. And with or without an epithelial component, because sometimes there's such significant stromal overgrowth. The biggest problem I see is that when we have a cellular fibroadenoma, and then we're trying to decide whether that could possibly be a low-grade phalloides and a benign phalloides tumor. That's the big issue. And the problem is that we can't really tell in core needle biopsies very effectively either. So we're left with these lesions, which on fine needle biopsy can show a cellular stroma, and they can show some necroatypia, pleomorphism, and we're trying to decide what should happen. I go back to the base situation. What's been happening clinically? If you've got a rapidly growing lesion, particularly in a woman who is probably older than 40, then you're going to take it out. It doesn't matter what the fine needle biopsy and core needle biopsy show. You may strike it lucky in the fine needle or in the core needle biopsy and find a cellular area of that phalloides tumor, which will then lead you to say this tumor should come out, because I'm now worried about a borderline tumor. But we have to remember that phalloides tumors, low grade, and even borderline to an extent, but particularly low grade phalloides tumors, can have markedly different areas within the actual tumor. And you get your excision biopsy and you look across it, and there'll be one little area of leaf-like architecture and increased cellularity of the stroma and some atypia, and then the rest of it might be sclerosed. So the problem with low-grade phalloides tumor is that on fine needle and core, we're sampling. You really need to see the whole lesion. So I go back to the brass tacks here and say, what is the clinical situation? Now, is the clinician and the patient worried about this lesion? Now, sometimes we'll have a 25-year-old girl, young lady, and the fine needle will come back and it looks cellular. And it can be very difficult for us to tell whether that's a cellular fibroadenoma or whether it's a low-grade phalloides. In that case, what's the clinical situation? What's the imaging findings? If it's a heterogeneous multilobated lesion on ultrasound or mammogram, but particularly on ultrasound, and there's any clinical concern, by all means do the fine needle in the core, but you're probably going to go with your clinical acumen and decide what to do. So we have a problem with cores, we have a problem with fine needles. It's partly sampling, and it's partly related to the fact that a cellular fibroadenoma, when you get a small amount of that lesion, can look like a cellular area of a low-grade phalloides. And we don't have any fancy immunochemistry to do either on the core or on the cell block. So it's a common problem.
So even a core needle biopsy really doesn't go a long way in helping and clarifying the dilemma. Last few questions, sir. Dr. Gagandeep Kaur is asking, how much material do you consider as adequate or enough in a cell block for reporting the prognostic biomarkers, ERPR, HER2/neu? I mean, if you have a very small area of cellularity in your cell block, would you be enough to decide the ERPR, HER2/neu on that, or would you like to have more adequate material in that situation and advise a biopsy?
I can't give you, 100 cells, 200 cells,
Okay.
but I think probably we're probably looking at a situation where over 100 cells before we'd feel really comfortable. Of course, we know that core needle biopsy and an excision biopsy can show you clonality, and you can have ER positivity in some areas and HER2 positivity, and other areas can be negative. But fundamentally, we do this all the time in situations where women have breast cancer and they get metastatic disease. Someone does a fine needle, doesn't matter what the site is, and we do our ERPR and HER2 on the material. And our clinicians are very happy to go ahead and act. We might say we've only got 20, 30, 40, 50 cells, 50 nuclei to assess. And they say, well, are they positive? And we say, yes, they're positive, 70, 80, 90, 100%. And they will act on that. Now, with a woman who's presenting for the first time with a breast cancer, we'd obviously want more material, but I can't say how many cells we want. You can have a core biopsy, which is exactly the same situation where you may get less than 1 millimeter of cancer in one little area of a core biopsy, and we'll do the ER and HER2. And no one asks that question, how many cells have you got?
True.
But oh, you're doing a fine needle. We want to know how many cells you've got. Exactly. So I don't have a precise answer, but it just depends on circumstances. Yeah. And in our environment, in Sydney, in Australia, in our breast clinic, if someone's got a cancer, they will probably have a core biopsy, almost certainly have a core biopsy. And we'll also, and then they may have a fine needle of the axilla. And in our situation, the clinicians want to know what's the status, the prognostic indicators in the breast. What are the prognostic indicators? Is the HER2 the same in the axillary met? So they'll want to know that prior to operation, because now what's increasingly happening in our environment is people having neoadjuvant chemo prior to their surgery. So there's a lot of pressure coming back on.
Yes.
But I can't tell you a specific number. But I think in our situation, we'd usually use core biopsy once we know it's a cancer. But think of all the cases, the women that don't have a core needle biopsy, if you've done the fine needle.
I think it's the same everywhere. If they're planning a neoadjuvant chemotherapy, locally advanced breast cancer, they would possibly go for a biopsy also. So, and I'll just take up one last question now, sir. Although there are, I'm sure I've missed out a couple of good questions as well. But one question was by Dr. Hina Ansari. She's asking, how exactly was risk of malignancy determined in the workup to the IAC recommendations? So I think that's a...
Okay, so we didn't go back to 2006 and look at studies which compared fine needle biopsy, core needle biopsy before they're actually using ultrasound. So I can put that on the line. We didn't go back to old literature. We had two major studies, one coming out of Porto and one coming out of Sydney. Okay. And we put those two together.
Okay.
The group in Porto were doing fine needle biopsy using, on palpable lesions, using ultrasound on some of their lesions or most of their lesions. They came up with their risk of malignancy based on positive predictive value, negative predictive value, and so on. We in our study in Sydney, we looked at two groups. One was a group of cases who came from the breast clinic I've just been describing, and another which came from a radiological practice where they did not have rows. And those two studies are both in Acta Cytological and published in 2019. And so we decided that we would use, with the whole group's consensus, we would use those risks of malignancy as established, because that's their current best practice. Okay.
So big thank you, Dr. Andrew. It was a pleasure listening to you today. And I think all the audience who attended must have benefited immensely from today's talk and must have been motivated to again try and revive the breast cytology as far as it is concerned. Of course, within the limitations and pitfalls that we know, which exist in cytology and which cannot be overcome. But of course, we must have, I think your talk has elaborately delivered this message that some of the pitfalls which we think are there in cytology also coexist simultaneously in core needle biopsies. So the most of the problematic zones which we know exist even on a core needle biopsy, and it's just that we should judiciously use FNA material on FNA smears as well. We can have some great results for our clinicians. So thank you, and on behalf of the Indian Academy of Cytologists, I would really like to thank you and my chairperson, Dr. Prabal Dev, Secretary Dr. Radhika Srinivasan, and all the esteemed members of the Academy and the audience who have attended today's talk. I wish to thank you all and let you know that we will be having more such talks in the future. And thank you, Dr. Andrew, for patiently answering all the questions and devoting your Saturday evening and spending time with the Indian Academy of Cytology. We are really, really indebted to you. Thank you, sir.
Thank you for the invitation. Thank you very much.
Thank you.
And good night.